Welcome back to another edition of the Hart2Heart Podcast. And my guest today is Dr. Boris Heifetz. He's an assistant professor of anesthesiology at Stanford. So, Dr. Heifetz, welcome to the show.
Thanks, Mike. Thanks for having me on. It's a pleasure to be here.
Yeah, so I saw your recent study, that publication with ketamine and anesthesia, and that's the main reason why I wanted to chat with you today, but there's lots of other reasons as well. But just before we get started, can you just give the audience a little bit of a brief background about yourself?
Sure. So, like Mike said, I'm an assistant professor of anesthesia. I squandered my youth collecting degrees. Did an MD, PhD in basic neuroscience, so like looking at slices of tissue and electrical signals and cannabinoids. This is early on. This is 20 years ago already. And then I did a residency in anesthesiology at Stanford, and then I did a fellowship at neuroanesthesiology. So one day a week, I take care of patients who have often devastating neurological injuries, aneurysms, things like that. I'm not a surgeon, thank God, but I basically get these patients through surgery safely from one side to the other. And that's one day a week. The other days a week, I run a basic science lab where we do like mechanisms of psychedelics, basically, is our full-time gig. And then also clinical trials. So we try and understand how this broad group of compounds works in people to basically create these psychological transformations that we keep hearing about and seeing.
That's awesome. And it sounds like a very exciting job. I'm kind of jealous of your job. I'd love to be studying psychedelics and psychedelic states and various mechanisms of action. It sounds pretty fun.
There's a lot of writing involved, unfortunately. Unless now, it's not what I thought like 20 years ago, but
maybe Chat GPT can help you out with the writing part in the future. You never know.
Already tried, but just hoping.
So let's kind of get into that one big study. So as we were kind of talking about before the show, I prescribe ketamine. I have done it for a few years. A lot of people have responded to it, really, really well. And it's becoming more and more prevalent. More and more people are interested in this particular molecule. The mechanism of action is something that is so highly debated. And, we can certainly get into that. We have that naltrexone study that shows there's some opioid involvement. Then we have, people that respond to R versus S ketamine. And then you have this, and then there's the BDNF. There's a lot of different things we can talk about. We'll try to, talk about all of them. But the big study that just came out was that, they gave ketamine to a certain group of people, and then they gave anesthesia to a group of people. And then at the end of the trial, essentially both groups improved, but they were essentially the same. So meaning that the ketamine, you can't really say necessarily it was a placebo effect. Maybe you can speak more to that, but what do you think is really going on there? Is it placebo, or is it more that maybe the anesthesia also provides a bit of a antidepressant effect?
All right, so you're going to have to cut me off because I have a lot. So this is a study done in my lab. It took a few years to get done. And incidentally, I co-led that study with naltrexone and
oh, wow.
with Nolan Williams here. That was my first clinical trial experience. And these things actually tie together: opioids, placebo, ketamine, in ways that we don't fully understand. But the nuts and bolts. Why did we do what we did? One of the enduring questions, if you spend enough time around psychedelic researchers, people are obsessed with this idea of, is it the drug or the trip, right? Everything in medicine is like, take this one little antibiotic and it'll, it's like, a guided nuke that is going to, clear up your infection. Take Ozempic or take right. It's all about drug design and like finding finer and finer targets. And that's sort of where psychiatry has been going too, mental health. And ketamine is a little weird in that it's not specific. It's not like it's a drug that does a lot of weird things. And one of the things people noticed very early on as they're developing it, this is 20 years ago now, and finding that it has these rapid antidepressant effects is, it seems to come with this like price tag of tripping, basically. And that's sort of how they were thinking about it at first, is that it's like, it works, but you have to sort of deal with this dissociative stuff. Mm-hmm. And, as before then, in Russia, people were doing studies. And since then, this whole ketamine assisted psychotherapy community has grown up around the idea. It's like, no, you got to lean into that. Like, that's the main thing, right? It's you gotta dissociate, you gotta trip, you gotta, that you have to dissolve your ego, and that's how you get better. So these two kind of ideas have been at loggerheads of, is it the drug or is it the trip? And how do you answer that? Well, you can try and like fool people, which I don't really like that idea in general, but of giving something that's sort of ketamine-like and like where they don't really know what they got, and see if, is it just because they know they got ketamine and they're in an exciting clinical trial? And it just doesn't really work that well, because you can't really mimic ketamine with another drug. And if you could, it'd probably be pretty effective too, because, it doesn't really answer the question of drug or trip. So anyway, to make it, put a kind of bow on it, that's where we started this process, is that we thought, well, if you could if you could give ketamine during general anesthesia, so you're being anesthetized with like conventional anesthetics, you're there for surgery, you're getting a knee done or whatever, you're also happen to be morbidly depressed, right? Just like all those other patients in those early studies. Well, if we gave ketamine or placebo to you during anesthesia, you're not there for it. You don't experience dissociation. And moreover, you don't know what you got. So whatever answer we get on the other side, after when you wake up from surgery in the next couple of days, that sort of tells you, we were hoping that would say, well, it's all about the drug, and all the trip stuff is what we call an epiphenomena. It's just like extra fun, but not really necessary. Or, we might, that was basically what we were hoping. Like, that's sort of how we designed the study, is to see, is that actually true?
And so do you then think that you do have to have a dissociative effect to get the antidepressant effect? Or do you feel that some people can get the antidepressant effect without the dissociation?
So what our study showed, basically, the short answer is, I think you can you can achieve psychological transformation without dissociation. I think that is a flat fact. You've probably seen it. I've seen it. That's the question is, how much of that is going on in these trials, right? It's hard intuitively to believe that your whole perspective can shift unless you go through something, right? So it's right that those things really seem intuitively tied. And what happened in our study is all the ketamine patients got better, like a lot better, and all the placebo patients got better, a lot more than placebo patients normally get, and far more than what we expect for patients having surgery. Surgery is a stressor, right? Think about like the worst day of your year is like planning to get your knee done. Like, my dad is, on his second knee, and like, he's done everything he can to avoid it. Basically, everything tends to get worse after surgery. Surgery,
Sure.
that your risk of heart attack goes up, stroke, kidney injury, lung disease. Yet somehow, like, depression is going to get better? Of course not. Like, people in the immediate aftermath of surgery are more likely to experience symptoms.
Because they're bedridden. Especially the patients you're talking about, like patients who have, with like knee replacements. You're talking about someone who obviously they were pretty limited before in their mobility, or otherwise they wouldn't be getting surgery. But after surgery, you're completely immobile. You're basically dependent on other people that almost do everything for you, at least for a couple of weeks.
Absolutely. And that's, when we're talking about ketamine, like the early studies looking at this, again, they're looking at what, this rapid acting effect. The fact that it kicks in 4 hours and lasts for a week, that's amazing.
It is.
That's not like anything we've seen. Well, now we've seen psilocybin and all kinds of other things.
And just to interject there, maybe you do or don't agree with this. There's no literature on this. This is just a hypothesis that I kind of have. But, we're trying, I guess, to tease out now, like, what psychedelic or medicine, obviously, ketamine technically is not a psychedelic. It's an anesthetic. But yeah, it has psychedelic experiences for sure. We're trying to tease out, I think, in the medical community, like, which molecule is best for which particular mental health disorder. Like maybe, MDMA is better for couples therapy and that kind of thing. For me, and again, this is just my own clinical experience, I find that ketamine is really good for suicide. Like it does bring out those suicidal ideations. And I have some docs who are some friends who are emergency room docs, and they use it there, and they say that they get very, very robust responses with that.
So this kind of gets at a key point, which is, our our study raises more questions than it answers. So when you hear stuff like that, it's hard to believe that's really all placebo, because you've probably been doing placebo, and at least with whatever else you've been trying with these suicidal patients, and that clearly hasn't been working as well as ketamine. So like, what gives, right? There are a bunch of things going on, right? Let's just sort of break apart what we think is happening when you like. I've never gotten ketamine from you, but I'm imagining that if I did, I would first of all have to find you. I have
You
to
would
do.
have to find me, yeah.
I'd have to do some work. And I'm motivated. I'm already. I want to get better. Why am I reaching out to you?
Good point.
And then what you're going to do is you're going to put up some walls, right? Because not everybody that contacts you is there to get better. Some people are there for other reasons, if you haven't provided ketamine. So now you're screening me. We're developing a relationship. I'm getting to trust you, your staff, your clinic. And so think about I want to get better. I'm putting my trust in these folks. And then so that all of this is clearly part of, of some transformative process, right? A road to recovery. Got to start with those steps. I don't think I'm saying anything controversial. And then the next piece is the drug, the thing itself. And if you don't make it important, nobody's going to care or remember. I had a bar mitzvah when I was 13. I got up on stage. I was nervous. I was all very, very, very anxious. And an hour later, it was all done. And my father said, "Today, my son, you're a man." And nothing changed. people treat me differently, right? I stepped through a door and it was over, right? It was there's the pre and then there's a post, and it almost didn't matter. All I do is show up, right? And this sort of gets back to this idea of you have all these non-drug factors that are critical for recovery. Again, people know this. It's not, what's the opposite of addiction is connection. People say that a lot, I think.
Yeah, I think it was it Jonathan Haidt, or no, someone different. I forget the guy's name who said that. The only thing with that, I do agree with that to a certain degree, and Michael Easter brought this point up in a podcast recently, is that, he said that when he was drinking, he had lots of friends, right? So he did have the connection, but then when he stopped drinking, he kind of lost some of his friends.
So I think what we're learning here is you can't apply
there's no one rule that applies.
And this is, and why then would we apply one rule to this tiny little beautiful pill, basking in a, glorious reflected light? If you've seen some ketamine ads, it's literally what they're showing, right? You're basically attributing everything to this one aspect. And we know that there's a much broader thing going on. And, you can think about it in three big contributors to recovery. And, you may not need all three. We don't really know. One is the your expectations, right? What you're bringing into it, your willingness, that sets in motion something that, after a profound experience can crystallize into a change. That's one part. The other part is the drug. It's possible that it's just all, we're just making 1,000 dendrites bloom in your brain, and whatever happens upstairs, your experience is kind of accidental, but we're programming in resilience. And if you're primed for change, maybe you don't even need to be primed for change. Maybe you can bypass all that stuff with ketamine. Maybe. The other piece is the experience itself. And I want to do a little digression here, because this is, I think, one of the most interesting things I've seen in anesthesia ever. I've been doing this for 15 years now, which isn't that long on the scale of things, but I've treated thousands of patients.
It's a lot of people. It's a lot of time. I've only been a doctor for about 10 and a half years, so that's a long time to me. So,
and I gotta give a shout out to my dear friend and colleague Harrison Chow. He was a community anesthesiologist, working at Good Samaritan Hospital. He's been doing this for years. And what this is about dreams with anesthesia. He's been inducing these dreamlike states for, people getting colonoscopies or cancers or whatever. And they come out and they're like, I feel so much better. My anxiety's gone. And so he tried, he's been doing it systematically. So
not to interrupt you, but just on that point, I've had patients tell me that I can't wait to get my colonoscopy done because I feel so good when I get it done, which is unreal because basically a person's saying I can't wait to get a tube stuck up my ass.
Yeah. That might be part of it. What are we to say?
Yeah.
That's totally, I mean, propofol, why was Michael Jackson so into propofol? It was really effective, right? Yeah. I want to be, we have a couple of different ideas floating around now, but what I'm bringing this up as is how just pure experience, without even a drug to tie it to, is so powerful. You think about jumping out of an airplane, right, or a near-death experience, and having a heart attack. Right? People make that's it's a showstopper, right? You're like, it's time, I need to make some changes, right? The longer you wait, the less likely those changes are to stick. But if you grab that window, this is just normal human responses to powerful experiences, right? It's not actually that mysterious. But what we've sort of manufactured this with dreaming. And it seems to work for particularly people with stress disorder like PTSD, recurrent nightmares. We published one of these. And again, this is all Harrison. Harrison is the man here. We armed him with a portable EEG and a psychiatrist and my red cap database to, put all the stuff in it. Anyway, he got this patient who was, she's young. She was attacked by a family member, defensive knife wounds, horrible, goes to the emergency room. Say, they patch her up. They said, go to Stanford, get definitive treatment in 2 weeks. He shows up, and finds her in pre-op. He's again inconsolable, still very much reliving that trauma, hasn't slept, hasn't eaten, really not doing well. And during surgery, Harrison does this thing. They basically block her arm, so they're doing surgery on her hand. And she's sedated. She's not deeply, anesthetized or comatose, but Harrison is kind of putting her in this light stage of dreaming. And we're looking at the EEG and she wakes up after 10 minutes of this. And now she's crying, but she's like, oh my God, it's over. She had the same dream, being attacked. And instead of rocketing her into conscious awareness, right? That's what nightmares do, right? You wake up in a cold sweat. The dream, instead of looping, it kept going. In her dream now, she's she goes to the emergency room in her dream. She goes to the operating room. She's back home, doing errands, looking at her healed hand, and it's done. She processed it. She processed a very traumatic experience. And we're like, well, is this real? Is this stick? And we talked to her the next day. We talked to her the next month. We talked to her the next year. She can talk. Again, you don't see this with people who undergo trauma, typically. She's able to talk about this experience in a total matter-of-fact way, right? She can touch it. She can touch the memory, and it's no longer painful. So
that's insane, and that's just from one experience.
I'm telling you, this is the wildest thing I've ever encountered in the operating room. We've done it a couple more times. Very similar story. It's under review. This first one is published. But the next couple are still under review, and it's early days. I'm skeptical of a lot of things, and I should bring that same skepticism to my own work. Our work with Harrison and Laura Hack and others. But the point, I started this by talking about the importance of pure experience. This is an experience. Yeah, we use propofol. We could have used sevoflurane. We could have used dexmedetomidine. There's any number of drugs. The point of this is state and in a pure experience that catalyzes a transformation, allows someone to process something. So really zooming out, and there's a lot going on here, but what I'm trying to draw attention to is when we think about how do people get better, right? there's you're setting the expectations play a role, the drug might play a role, and the pure experience might also play a role, and how these things relate to each other. It's actually fantastically complex, right? Can you replace part of the experience with a drug effect? Can you replace part of the expectancy with a drug effect? Can you replace the drug effect with an experience, like a pure experience? Like, it's right. Like, you see how like all of these elements, it's some of them come together in unintuitive ways, right? Like the idea that you could I could walk into your brain right now and make 1,000 dendrites bloom and program in resilience, to trauma without you even noticing anything happen. That it's a wild idea.
It's wild that lady, like, I'm almost thinking now, it's almost like she healed herself. Like she was like her own therapist. Like that's like she didn't need someone to guide her through that dream or to guide her like to the emergency room to get her surgery, to go back to, get errands and get back on track. Like she did this on her own. Like it was like, the ketamine had like a therapist with her in her dream and showed her that this is where you want your dream to go instead of where it was going before.
That's such an important point. And that, part of my skepticism about the field, like psychedelics, the boom, is that like, are psychedelics endowing you with superpowers, or are they basically allowing you to do something that your body was capable of doing anyway? Is it really reopening something that like only a psychedelic can do, or are you basically repurposing a very normal program that's present in all? Like you can do this at 80 and you don't need psilocybin. You need something though.
Yeah. It seems like, what makes people happy for, to put things simple, is just pro behaviors that are helpful for your health. So like, working out, sleeping 7 to 8 hours a night, community, getting good nutrition, a lot of like the basic things. And I think that if you use a psychedelic, sometimes it can be the catalyst that you start doing some of those things. So it's not that the drug is not extremely powerful. It is, because I just said it's a catalyst, but it's the things that you do after that make it work. Like when you followed up with this lady 30 days later, or 3 months later, a month later, she wasn't sleeping all day in her bed. She was probably going out and seeing some friends. She probably had, got some exercise. She probably, was just doing things that were, pro-healthy behaviors versus, depressive behaviors. Like depressive behaviors would be the things that, I just mentioned, like staying in your bed all day or not having any social, communication with others. So I think that it's like the drug is definitely doing something, but it's also, the behaviors that come after you've taken the drug that really produce the long lasting effects.
In a way, like that's the most important is like what change crystallizes, and it's not going to crystallize on its own, right? Today, my son, you're a man, and it only counts if everyone in the room looks at you differently and like, now I act differently, right? I mean, something else is expected of me now, and you step up. And the same way, like you got to create structures in your life that are going to allow you to transition and make changes.
New actions will make new brain circuits, correct?
I don't know of any other explanation for how new actions become habit. Yeah, like I think that's pretty accurate.
And just coming back to the naltrexone study, and forgive me, Dr. Heifetz, I didn't know that you were on that particular paper, but congratulations, that's awesome. So in the particular study that I'm talking about, obviously correct me if I'm wrong and you'd be the guy to correct me, but you gave naltrexone to patients before you gave them ketamine, and then unfortunately, well, however you look at it, I'm saying unfortunately, those patients didn't respond well to ketamine, or they didn't get a robust depressive response, antidepressant response. So in that regard, again, we understand this is a very, very complicated molecule. Treating depression and mental health is very complicated, but do you feel that there is some opioid receptor involvement going on with the ketamine and its alleviation of depression?
So that's where, we want to find out. That's what the science is for, I think. I want to just draw a link here that I think is an important one. And it ties together placebo and opioid system and ketamine, and what we saw in our anesthesia trial. So in our anesthesia trial, again, all the patients who got ketamine got better. They got a lot better. All the patients who got placebo, a lot better. We're never disappointed to find out they were in the placebo group or asleep for it. And they knew they went through something big and that their people cared. There's a lot of, I think, factors that factored into that big placebo response. So if, the placebo effect, like what is the placebo effect? Placebo effect is expectancy, right? Expectations. There's been a lot of research actually on how does placebo effect work? Placebo effect is like any other effect in that it clearly, it's got to be, something between your ears at some point has to account for the placebo effect. That thing that happens, it uses, neurotransmitter systems, on some level. And there's great studies in the 80s, 90s, and, going on where you give people naltrexone, an opioid, and you block the effect of expectancy, right? You can do placebo analgesia studies. You tell people, I'm going to give you something that's going to make you feel, going to make this less painful. And it works this way, and there are studies to show it, and people will get better. They'll say they feel less pain, right?
So you give something to block the opioid receptor, and then you give opioids, and then the people still report pain relief, even though it's scientifically impossible for them to get pain relief from it. Is that correct?
Well, it's the other way around. That they'll normally, if you told me that you're going to give me something, like I take, Aleve, every week after I play tennis, and, and if you basically told me, you're giving me Aleve, and you say, I'm giving you Aleve, it's going to help, and you actually give me some sugar pills, I'll still get better. Very likely. Yeah. There's a conditioned response, and there's some expectancy. You can block that effect with naltrexone, as in you can block the placebo response.
Oh, okay. So you're blocking the placebo response with naltrexone.
And what it suggests, and what there's now a fair bit of evidence to show, is that the placebo system actually is it relies on your endogenous opioid system. Endorphins, for example. What happens when you set an expectation? When you have an expectation of getting better or feeling less pain, somehow, somewhere in your brain, and we're narrowing it down, there's endogenous opioids released, and that system is responsible for that placebo analgesia, right?
Very interesting.
So let's now put some stuff together now. If we think that ketamine has hijacks this expectancy circuit, right? This is kind of an out there idea, but right, how does ketamine work? We don't really know, but we know that placebo works. And what if you had a super placebo, something that could just forget all of that, talking and stuff that I have to do to drill an expectation into your head, and I just nailed that neurotransmitter system with the drug and producing all the same effects. That is one way to think about ketamine, and that's actually what, if you put all these studies together, sort of what it's suggesting. You can block ketamine's effect with naltrexone. You can mimic ketamine's effect with a very strong placebo, right? This, what we did with anesthesia was, there's a super placebo, this was it. We gave people freaking surgery, right? A big, you're in this trial. We sought you out. We're caring about your mental health. We're going to hold your hand as you jump into the abyss of unconsciousness. It will be there when you come back out. And you might have gotten a drug that might make you much better.
It's kind of a crazy study when you put it that way.
Right? So that's that's not what we set out to do at all. I was just so happy to get any patients in our study. But when we got them, we had to make sure they knew, why on earth would you want to do a study when you're doing surgery? Right? It's because we care about your mental health. You might get better. You might not, but you might. Right? And it's it's really you don't think about this sort of messaging until way too late.
I was going to ask you, in those two particular studies, the anesthesia study and the naltrexone study, what forms of ketamine did you use? Was it R or S ketamine, or was it a mixture of both?
We stuck, again, what I want to be really clear on this point, which is not the question you asked.
Okay.
Is that people misinterpret this work as saying ketamine doesn't work. Ketamine is like, a super opioid. Whatever, just actually to go back a minute, whatever else is going on, does ketamine have opioid-like effects? Probably. Is ketamine abusable? Definitely. Is it as bad as heroin or nicotine or alcohol? Probably not. I think it's probably safe to like lay that out there and say like, you got to monitor and, be on the lookout. It's not like, it's like anything else, risk and benefit.
Yeah.
But
one nice thing about the abuse part, I will say, is that, it's difficult to abuse in some ways because it's hard to get access to it for a lot of people. I mean, not for some.
Well, why don't you change that?
Not for some. And then for myself, so I'm just a GP, so I only prescribe it to people orally. And, if you take it orally, unless you take it on an empty stomach, even the sublingual lozenges, you're just not going to get a pronounced effect at all. So, if you have food in your stomach and you try to abuse ketamine orally, it's not going to work, but it does have a lot of abuse potential for abuse for people as well.
It does. I mean, that's the bottom line is it's not, it's not the devil or the boogeyman, but it's like, you have to, monitor. So people need to be aware that this isn't, do you see what's the Netflix, the Painkiller?
I saw Painkiller. I loved it. I was surprised just because, like when I come home, it's like, I don't want to do more medicine, but then I came home and I loved it. It's awesome.
And also props to Matthew Broderick for, anyway, the true.
Hard to take Ferris Bueller though, seriously when he's the bad guy. You know what I mean?
It sort of makes him a little bit, anyway. But that, so is it OxyContin? No, but, if you give it to enough people, even something with a little bit of abuse potential, can cause harm. You gotta be aware of it. But you asked about like what type of ketamine, and I was going to digress and just emphasize that in all these mechanistic studies, and that's what these are, we're trying to get a mechanism. This isn't about how do you get people better with, right? Because there's a whole other, and this from your practice, I'm guessing, you get multiple rounds. You do like induction, you do maintenance. Like there's a literature there. We've contributed to some of it, looked at, hundreds of clinics, thousands of patients. Patients get better. And this is not about that. We're giving a single dose. We're trying to assess that rapid effect. We want to know how it works, right? So really like a reduced system here. I just want to get that out. As part of that, why did we choose 0.5 milligram per kilogram of racemic ketamine over 40 minutes? Doesn't make any sense, except that that's what everyone used for the first 15 years of ketamine's life in psychiatry. That they just, so a group at Yale decided that this would be a good way to not get people too like far into outer space. So let's spread it out over 40 minutes. And the problem is ketamine is a drug that's used is approved for anesthesia. So the patent life would basically run out. So, well, what do you do when your patent runs out? Well, that's, omeprazole becomes esomeprazole.
Yeah.
Citalopram becomes right? So you take the one enantiomer, you get some IP around it, and now you have like a market basis for your drug. So that's what they did with S-ketamine. That's Spravato, and they changed the delivery. Now it's intranasal instead of IV. You gave ours IV. But the point is, in our study, we're really just trying to copy these foundational ketamine studies. This is not a comment on whether S works better than RS, R work. That's a different issue. Also interesting. But yeah.
Can you shed any light on that? If there is any light to shed?
I feel like I might get in trouble with some mafia somewhere for this, but S-ketamine does not. I mean, the FDA, like the packet, right? When you look at the stuff that S-ketamine was approved on, most of the studies were negative. There's only one positive study at that packet, meaning that, like, again, S-ketamine has undergone actually more rigorous evaluation than ketamine. It's been in more people have been through randomized controlled trials because there's financial incentive. There's money for it. and again, this isn't like capitalism is bad or whatever. Our system sucks, but there is some good. Like when you have a incentive and you get capital, you can do large controlled trials, which we think we right.
Yeah. And another important point though, too, and this kind of comes back to what you were saying earlier about like, expectation. And, I work in Canada, so it's so easy for, me to say this and look good. But like there are people now coming to Toronto. I'm in London, so I'm about 2 hours from Toronto in Ontario. But there's some people coming here and they're, opening private practices with ketamine, but they're charging like exuberant amounts of money to treat these patients. And again, I'm not saying I'm like Mother Teresa or anything, and I'm lucky that I'm working in Canada, but like I just do it for free for my patients, and the medicine that they get is incredibly cheap. And so, it's unfortunate that like a lot of the people who really need it, don't seem to have that good of access to it overall, because I can tell you these patients that I have, they can't afford $5,000, they can't afford $1,000 or even a couple $100 a lot of the times. And I do feel that, it's something that we do need to work on like a little bit more. And then, just coming back to your other point with regards to like the expectation. I mean, if you're going into, an elaborate facility and somehow you have, $5,000 or $10,000 to go through these ketamine sessions, you probably also have, someone to help you out at home. You probably have decent living circumstances, things like that. But if you're in the community, you're really desperate, you're, on the poverty line and you take ketamine, the expectation is still that you're going to get better, but, you have to be realistic that, this person just doesn't have the same social supports, the same income as, someone who's going to a private practice and, giving some doctor 5 or 10 grand to do a few ketamine sessions.
This actually, what you just said is, I think, a really big blind spot and an issue for psychedelic medicine. You brought up this idea of an inner healing intelligence. Thank you.
I did. Yep.
And it's, is when you start thinking, that sort of, that concept only goes so far. Folks like what who you describe who don't have the resources, like it doesn't matter how, powerful your inner healing intelligence is if like the situation you're living in is directly contributing to your mental health issues. And you go from, a ketamine session back into those. I mean, MDMA, you have like this like heart opening MDMA session and you go right back into the living circumstances that created. You see, like,
yeah,
it is a complicated issue, and it really makes me like access to care it's not just like, can you get the drug? It's sort of exposing broader issues in our mental health system, and that like, what does insurance pay for? Insurance pays for a drug and procedures, right? What, you have a drug that's off patent, right? Ketamine is dirt cheap. MDMA is like unpatentable. Psilocybin grows, right? So like, what's the model here? Like, again, like the pharmaceutical industry has done good. And I'll say that unequivocally. We've cured hepatitis C. That's like, nobody, I don't think you can argue with that. Like, that's like, it's amazing.
It's unbelievable. It's unbelievable.
But again, that's a very different concept. What you're talking, you have a drug, all of this monitoring and procedure, like things that insurers understand and like regulators understand, right? Like it's built around that. When you're talking about like improving someone's home situation, what insurer would ever pay for that? For like, home monitoring for like, get some time off of work. Like that's nuts. Of course, that's what you need, right? But that doesn't really, it's not like, it's too hard to like put make it real, like make it objective, like like, how do you judge what someone needs, right? It's just, you can see where difficulties come up very quickly in like, how do you adjudicate stuff like this in the society?
I absolutely, and I wouldn't say it's like futile, but like if someone has a very difficult situation and then you put them through, ketamine sessions for a week, and then they go right back into the exact same situation. Like I'm saying right now, like unfortunately, that person probably isn't going to have long-term effects that are long-lasting. And so I think like when people do these treatments, they have to have some kind of aftercare set up, because if they don't, then they're probably just wasting their time and wasting their money in a way, because it may make them feel better temporarily, but it's certainly not going to last very long.
That's what I. It must sound a little funny coming from someone who spends all their time in like not literally an ivory tower, but like I recognize I've lost touch with a lot of reality. The patients we see reflect a pretty diverse group of folks, but I don't deal with what you're talking about in a direct way. But it just strikes me that it's such an important piece of it, right? That like how that's really what we should be focusing on, and it's going to take some people way smarter than you or me, I think, to like really figure out how to enact that change. Like it's community based, right? This is like
that's not something that's easily fixable, and it's not really something that physicians like can fix. We can administer drugs, we can counsel patients, but we certainly can't fix their home life. That's
I'm
not.
sure plenty of patients want you to do exactly that.
Yeah, I think most of them do, unfortunately, but it's just not an issue that I can truly fix. I know we have about 10 or 15 minutes left, and I did want to ask you one particular question. So, again, a lot of patients who are seeking ketamine obviously are struggling with mental health, and when a lot of people who are struggling with mental health are already using psychotropic drugs. So whether it's an SSRI, selective serotonin reuptake inhibitor, a SNRI, or whatever medicine that they're using, we know that if we combine those medicines with things like psilocybin, then there can be big contraindications. So it's a big no-no. Although I will say, I think there was one study on escitalopram where they prepped people for 10 milligrams for 2 weeks, and then they didn't find there was an effect, and we can chat about that a little bit. But coming back to with ketamine, one thing about ketamine though is that if you are on antidepressants, it's not contraindicated versus if you wanted to do like a psychedelic trip, say with like MDMA or psilocybin. So I think ketamine does have a big advantage over those medicines just for that one particular reason, because again, most people who want to use these drugs are probably already taking a psychotropic drug that's contraindicated.
It's a big when you talk about scalability and what's the science for, is that's something that the pharmaceutical industry should be good at, is redesigning these drugs in a way that at least makes them compatible with SSRIs. As you just said, like that's our we can see it in mice, we can see it in people. If you're on SSRIs, MDMA is not going to work nearly as well. And how do you so the one of the, I think, wonderful things, and I started, I did my field research, so to speak, in the 90s, and I've been like very interested in this area for a long time. I'm very I'm aware of how transformative these treatments can be. It's at the same time, like the drug industry, for all of its faults, this should be what it's good at, is redesigning a molecule like MDMA so that to get around issues like that, so to provide the same type of experience while not forcing people to come off of medicines that may actually work for them, or they may just be unable to come off for any number of reasons.
And also too, I think there's a lot of people who are, and like rightfully so, I totally understand, they're just afraid to trip. Like they just don't want to freak out. They don't want to trip out. So if there's a way, I think they're trying to design, the drugs, and some of the people who obviously enjoy tripping out are not going to like this, but they are, I think, trying to design some drugs. You would probably know a lot more about this, where you do get the antidepressant effect, but you don't necessarily get the tripping effect. And then this comes again back to the point, like, do you have to trip to get the experience or to get the beneficial effects. And, some people will say yes, some people will say no, but I think that we will be able, hopefully, to be able to develop some drugs where people don't have to have that experience if they don't want to. But again, if you want to have that experience, I totally understand why someone would want to have that kind of experience.
This gets to like that, there's unlikely to be one answer, that there are some people, I guarantee you, there will be people for whom you take one of these drugs and it's transformative and we're never going to know why. And we encounter this all the time. I had patients say, I went to sleep for a carpal tunnel release and this voice on my shoulder that had been there for 20 years was gone. And it's like I don't know. Like, can we do it twice? No, we can't. It's irreproducible. Like, it's real. I am convinced stuff like that is real, but it's so hard to nail down. Like, you're never going to see it twice. Like, what are we going to do? Anyway.
Is it something to do with the BDNF, you think? I know there was they did that knockout mice with the BDNF and then they didn't respond to ketamine.
There's a lot of interesting ideas out there. What is, I think, the most interesting is that so far, very little has jumped from mouse studies to human. Is it things we predict in mice? That goes for, in particular for ketamine. There are a couple of studies that, all the things, we kind of put mice in a vat of water and swim around.
Yeah.
And like, you're depressed now. Like, okay, maybe they are, maybe they're not. But whatever we learned from that, which there's like kind of like a palace built, of like molecular mechanisms and mTOR and BDNF and AMPA and all this stuff. And then you make some simple predictions like, well, if I give you this inhibitor, that should block the ketamine effect in a human, because it did it in a mouse when we looked at them swimming in water. What happens when you give it to people? They are better for 3 times as long, right? You tripled that, right? It didn't block it. So what I'm getting at is and I do this research. And so I try and apply the same skepticism to our own work. But when, trying to really attribute, these drugs and how they work and like what we see in mice to what we see in humans, we have a long way to go.
And with rapamycin, I know there was some pre-treatment about that, but I think actually we're on the same Google groups. I think I actually asked that question on that email thread, and then everyone was kind of like, yeah, I tried it and it didn't really work out, or it doesn't seem to be reproducible. Whatever that particular study was where they gave the rapamycin before treatment, they got much better than the people who were only given ketamine and not rapamycin.
So that's actually the real headline is, how sometimes stuff in clinical trials doesn't, hold up in actual practice. But again, it's a clear prediction from the basic science. That, I think, what's remarkable is that it should have, like, if all of this mouse stuff is right, that rapamycin should have blocked ketamine. There, you can hem and haw about why it did or it didn't, but, you can look, I can find, 5 examples right off the top of things that clearly work in mice, that along that same mechanistic line that just don't hold up in humans. And again, like, you can make up stories, but at some point, you have to start wondering, like, are we looking at the wrong thing in mice? And also, can you really translate this down to, something, a brain the size of my thumb? Yeah. It's not going to look the same if it's there at all. Like, and that, again, nobody, you don't really like to hear, like, we don't know, but we don't know.
Yeah. If someone was taking a lot of opioids, luckily I don't have many patients take opioids because I, feel that they're, not good for the long term. But if someone is on a lot of opioids and they take ketamine, would you expect them maybe to have a little bit of a less robust response because maybe they would have less of that placebo effect?
So that's a good question. People, we actually came out with that naltrexone study, which gets at that question. A lot of people wrote in and, published their own studies. We're like, look, people are still getting better, even though they're on Suboxone, they're on methadone. And again, like this really does require some careful controlled research. I can tell you that in our own data set from this surgical study, right, we did have a bunch of people. We tended to exclude people who are on high doses of opioids for that reason.
Okay.
But what we did find actually is that one of the things that seemed to relate to poorer response was higher opioid use. Again, why are they on opioids? There are a lot of other, a lot of confounding factors. But to me, that actually I think there is some suggestion that if you're on enough opioid, you run the risk of blunting. But again, like I want to kind of bring it to reality for a minute. Is you're seeing patients, you're getting them multiple rounds, right? You're doing all of the prep, you're doing some integration with them. There's going to be all of the other factors that you're working. We're talking about like the isolated drug effect of ketamine in the absence of all those other things. That's the beauty of doing a study in anesthetized patients, is we can get some sort of clarity, right? But in reality, like, you're leveraging all these things. So should you not even try ketamine in someone who's on opioids? Absolutely not. Like, right? If use your, I should say absolutely not, but use your medical
judgment.
Right?
Yeah.
There's no reason it can't work by, some of these other pieces of the whole puzzle.
Okay. And one last question I have for you, and you can answer this honestly. So, family doctors like myself, or like we were talking about before the show, we treat patients with the SSRIs, SNRIs, those various different psych drugs, ADH, meds. Do you feel that ketamine falls into the care of family physicians, or do you feel like that should be delegated more to anesthetists and psychiatrists?
I think it's safe. It's fundamentally like physiologically, I think it's safe. I think that it's best practice is to have some sort of mental health practitioner in the loop, right? If you're prescribing ketamine, maybe, there are models out there where you prescribe the patient ketamine and you send them to a therapist, and they do it with the therapist, right? The amount of medical supervision, again, use clinical judgment, but that's not the main issue. To me, the main issue is psychological safety and the factors you need for efficacy, right? It's not I don't know exactly how your practice is set up, but sometimes you don't have the bandwidth really to do what needs to be to really maximize the effect.
Yeah, no, you're 100% right. Like, I wish, all of my patients could, do some type of therapy with their ketamine, and I certainly encourage them to do that. But unfortunately, some people just don't have the means to do it. So you try to make some kind of bridge and have them take it at home in a safe way, very, very low dose, which again, unfortunately, they won't get. Although I will say you can still get a pretty robust response, even with a mild to almost no dissociative effect. So I appreciate you answering that. So before we wrap things up here, can you tell everyone where they can find you online, what your Twitter handle is, and all that kind of stuff?
Sure. I'm on Twitter X as @TheBorisLab, TheBorislab. I mostly tweet about science. And my website is on Stanford website, but it's Heifetz Lab, HEIFETS lab.stanford.edu.
Awesome. Well, it's been amazing chatting with you today. I can't believe how much I learned. I took a bunch of notes, so I really, really appreciate you sharing all this information. And for everyone listening, thank you so much for listening. And as always, I'll be back again next week.